Morning dear students, the topic is pulmonary function test. So the pulmonary function test involves careful history taking and meticulous clinical examination and taking the chest x-rays. So what does this pulmonary function test do? So they help the clinician to make a physiological assessment of the lung function rather than to make a pathological diagnosis. So we'll see the indications of pulmonary function test. So diagnosis of pulmonary diseases for confirmation of clinical diagnosis and for exclusion of the diagnosis. To follow the prognosis of disease and its response to treatment. To assess the severity of disease, and it is used as a pre-anesthetic assessment of respiratory system. And to assess the physical fitness for certain jobs involving strenuous physical exercise. And to obtain medico-legal information in certain situations, and for studying the prevalence of respiratory disease in a community. And next is classification. Classification of pulmonary function tests. So they are grouped into 4 types. So one is ventilatory function test and tests of diffusion, tests of ultimate purpose of respiration, and tests during exercise. So coming to the test for ventilation, so there are 4 categories here. So we have to measure lung volumes and capacities, dead space, compliance, and airway resistance. So all these topics are already covered in the previous classes. So now we will see in brief or mostly the important points which are measured in these various tests for ventilation. So the measurement of lung volumes and capacities, we have seen the definition and values of these volumes and capacities. So now we'll see the method of recording or measuring these volumes and capacities. So it is by using a simple spirometer. So here we can see it is a simple spirometer, and there are also other spirometers like respirometer, which is a modified spirometer, and computerized spirometer. And the spirometry refers to the recording of volume changes during various clearly defined breathing maneuvers. That is, certain breathing maneuvers the patient or the subject is asked to do, and while he is performing those breathing maneuvers, we have to record the volume changes using the spirometer. And the graphical record of those volume changes is nothing but spirogram. So this is a small video clip for the procedure of spirometry. So she will explain the parts of the spirometer, and then the method of performing the spirometry. So before doing the spirometry, we have to give some instructions to the subject, like he has to the examiner has to explain the procedure thoroughly to the subject before, and then only he is asked to breathe through the mouthpiece of the spirometer. And also the subject is asked to breathe normal tidal respirations a few times before doing the spirometry. And then he is asked to inspire as deeply and fully as possible. And the nostrils should be kept closed with a nose clip or with the thumb and index finger. And then we have to take 3 recordings at intervals of 5 minutes. And then the maximum volume of 3 readings should be considered as the reporting value. So now see the video.
We will discuss about spirometry. Spirometry, that is the method for measurement of lung volumes and capacities. Here we use Hutchison spirometer to measure lung volumes and capacities. Starting with the instrument description. Spirometer is an instrument used routinely in physiological and clinical studies for the determination of lung volumes and capacities. Spirometer consists of double-walled cylindrical chambers. In between these 2 cylinders there is water, and this is to maintain airtight seal. Next part is bell. It is a cylinder of 9-liter capacity made up of lightweight metal, you can see here, which dips into this water from above. This is the bell, you can see. The top of the bell carries here a hook to which a chain is attached. This way. The chain passes over a frictionless pulley. This is pulley. carries a counterweight. Here counterweight is there on the other end of the chain. It is attached. The pulley is calibrated and the markings, they are from 0 to 6500 with a pointer which indicates the reading which we are obtaining during the measurement. It has also a mouthpiece and corrugated rubber tube which is connected with the inner cylinder. We also require potassium permanganate solution as an antiseptic. Let us perform tidal volume. Tidal volume is the volume of air that is inspired or expired normally during quiet breathing. First, set the pointer at 0 mark. Ask the subject to dip the mouthpiece in the potassium permanganate solution. Ask the subject to inspire from atmosphere and expire in this spirometer mouthpiece with nose closed. The graduated dial moves against the pointer and its position at the end of procedure gives the volume, that is our tidal volume. Normally it is about 350 to 500 ml.
So the same spirometer is present in our laboratory also. So when you come back to college, so we will be doing this spirometry practical in the laboratory. So the next slide will be seeing the measurement of vital capacity using spirometry. So this measurement of vital capacity is a short question for you in the practical. So see this video very carefully.
The maximum volume of air that is expired with maximum effort after deepest possible inspiration. Procedure: again set the pointer at 0. Ask the subject to inspire maximally from atmosphere and expire forcefully and maximally in the mouthpiece with nose closed. Normal readings obtained are 3200 ml to 4800 ml. Here our reading is 3500 ml. Following capacities can be calculated.
So out of the various lung volumes and capacities, more useful pulmonary function tests are vital capacity. So in the vital capacity, there are slow and forced or timed vital capacity. So slow vital capacity is nothing but the volume of air expired after maximum inspiration during slowly performed maximum expiratory effort. So it is used to evaluate the size of the lungs. So forced or timed vital capacity is the amount of air expired with maximum expiratory effort after a maximal inspiration. So FVC is reduced in restrictive disorders such as kyphoscoliosis, pleural effusion and pneumonia, and also conditions producing trapping of air due to collapse of distal air during the forced expiratory maneuver. And the components of FVC, as we already know, it is FEV1, V2 and V3. So which is nothing but forced expiratory volume at the that is at the end of 1 second of FVC. Likewise, same for FEV2 and FEV3. So the FEV1 and FEV2, FEV3. So these out of these, FEV1 is most important in differentiating the obstructive and restrictive type of disorders. So now we'll see the different obstructive and restrictive type of disorders. So the obstructive disorders are nothing but they are characterized by reduction in airflow because of decreased airway radius, and particularly the FEV1 is reduced and also the FEV1 by FVC ratio is decreased. And the restrictive disorders are characterized by reduction in lung volume, and it is specifically the total lung capacity reduced less than 80% of the predicted value. Okay. So in obstructive type of disorder, as you can see, in the picture. So this is the normal lung and this is the obstructive disorder lung. So here the total lung capacity is increased. So the forced expiratory volume in 1 second, that is FEV1, is decreased. The forced vital capacity normal or decreased, and FEV1 by FVC ratio is decreased. Total lung capacity normal or increased. Residual volume increased. So this is the residual volume. And it is a restrictive type of disorder. So here this is the normal lung and this is restrictive. So here you can see the size is decreased. So forced expiratory volume FEV1 is normal or increased and FVC is decreased. FEV1 by FVC ratio is normal or increased. Mostly it will be increased. The total lung capacity is decreased and residual volume is obviously decreased. So this is a flow volume curve. So what is it? It is the rate of airflow noted during the maximum expiration, which can be plotted against a volume change to give a flow volume curve. So here in this picture you can see the y-axis shows volume in liters and x-axis shows time in seconds. So this loop graphically depicts the rate of airflow on the y-axis and total volume inspired or expired on the x-axis. So this curve or loop is dramatically altered in obstructive and restrictive diseases. So due to some technical problems, this curve is not routinely plotted in all the clinical respiratory laboratories. But this is definitely helpful in the research purposes. So again in this picture, it is showing the normal spirometric flow diagram, otherwise flow volume curve. So the smooth lines, expiratory time of greater than 6 seconds and the quick peak of the peak expiratory flow rate indicates a good spirometry effort. So here it is the peak expiratory flow. So this above curve is during expiration and the below curve is during inspiration. So we can see here, and this volume during expiration, it is sudden rise in the curve we can see. So this peak is called peak expiratory flow or PEFR, and here on the x-axis we can see here it is FEV1, that is during expiration in 1 second, and this one is the total vital capacity. So in this slide we will be seeing flow volume curves or spirograms of the different types, that is obstructive or restrictive ventilatory disorders. So in the middle picture it is showing normal spirogram or normal flow volume curve. So this is expiratory and this is inspiratory curve. So the first one is restrictive ventilator defect. Here what is happening? We can see the total lung capacity is decreased and the FEV1 by FVC ratio will be increased. And here it is showing obstructive ventilatory defect. So here we can see that the lung capacity is increased, residual volume is increased, and here there is not so steep rise and the expiration. So while exhalation, it is also the curve is very slow, very long. So this is the difference between restrictive and obstructive. So what is happening? Residual volume is increasing, the FEV1 is decreasing compared to the restrictive. And coming to the limitations of spirometry, so it is this maneuver is highly dependent on patient cooperation and effect, and normally repeated at least 3 times to ensure reproducibility. And since the results are dependent on patient cooperation, FEV1 and FVC can only be underestimated, never overestimated. And it will be only useful when children are old enough to comprehend and follow the instructions given, typically about 4 to 5 years old. And contraindications to spirometry are acute disorders affecting test performance like vomiting, nausea and vertigo, hemoptysis of unknown origin, so it may aggravate the underlying condition, and pneumothorax, that is air in the thorax. recent eye surgery which increases the intraocular pressure during spirometry, and recent MI or unstable angina, and thoracic aneurysms which have a risk of rupture because of increased thoracic pressure. And the next value which is measured by the spirometry is important values, peak expiratory flow rate. So what it is, it refers to the maximum rate of the airflow observed during a sudden forced expiration from the position of full inspiration. It can be measured by simple device called peak flow meter. The best of three efforts should be noted. It is a good and reproducible measure of degree of airflow obstruction. So we'll see a small video regarding this. This is a peak flow meter, as you can see. So the patient is blowing air into the mouthpiece very forcefully, and note the reading. The next important capacity is the functional residual capacity. So as I have told you, it cannot be measured by the spirometry. So it is measured by using nitrogen washout method or helium dilution method. So first we will see nitrogen washout method. So it is based on the assumption that alveolar air has 80% nitrogen. So in this method, subject is made to wash out nitrogen from the lungs completely by inhaling pure oxygen for 5 minutes and expiring into a large gas bag called Douglas bag. So here, so wash with pure oxygen and hence made nitrogen free. So this bag is made nitrogen free. So the volume of gas collected in the Douglas bag and its nitrogen content are measured, and the value of FRC is calculated as, so initial amount of nitrogen in the lungs is equal to total amount of nitrogen exhaled. Since the nitrogen content of the expired gas is solely from the subject's lung, where it forms 80% of the gas present in the lungs, that is FRC. Therefore, FRC is equal to V exhaled, that is volume of air exhaled multiplied by concentration of nitrogen in the exhaled air divided by concentration of nitrogen in the alveoli. So here if we put the values, that is volume of exhaled air is suppose 2000 ml, and the concentration of nitrogen in the exhaled air is obviously 100%, and as we know the concentration of nitrogen in the alveoli is assumed as 80%. So if we put the values, we will be getting approximately 2.5 liters. So that's how we'll be calculating the FRC. So once we get the FRC, we can easily calculate the residual volume. So that is RV is equal to FRC minus ERV. So we have to know the FRC and ERV. So then we can get the residual volume, and also from the residual volume we can get the total lung capacity. So TLC is equal to VC plus RV. So that's how we will be getting all the lung volumes and capacities. So this is a helium dilution method of estimating FRC. Here we can see there is a closed circuit system which is prepared with a mixture of helium, oxygen and air. So the amount of helium added in the mixture is such as to achieve 10% concentration of helium. The subject is then made to breathe in the closed system till the concentration of helium in the lungs and the bag become equal. So the concentration of helium in the lungs and the bag become equal. So the helium concentration is measured at the end of normal expiration, because FRC is the volume of air remaining in the lungs at the end of normal expiration. Since no helium was present in the lungs to begin with, the same amount of helium was added to the mixture in the closed circuit system will be distributed between the bag and the lung. So the basic principle for this method is CV, that is concentration of helium multiplied by volume of helium initially is equal to concentration of helium and volume. So here the final volume will be volume of helium and FRC, that is functional residual capacity of lungs. So from this formula we can calculate easily the FRC. So the patient is connected to a spirometer containing a known volume of gas with a known concentration of helium, and helium is not metabolized by the body. So the patient begins to breathe normally. Helium concentration will change as the helium gets diluted in a larger volume of gas due to patient's lung volume, that is V1 plus FRC. The final helium concentration is measured. The value for FRC can then be derived since 3 of the 4 values are already known. So C1 multiplied by V1 is equal to C2 multiplied by V1 plus V2. So here V2 is the FRC. So V2 or FRC is equal to V1 multiplied by C1 minus C2 divided by C2. So from this formula we can get the FRC value easily. So this method measures the volume of gas in the lungs which is participating in gas exchange. It will underestimate the FRC if there are significant areas of gas trapping. Next is measurement of dead space. So dead space is the portion of minute ventilation that does not take part in the exchange of gases, or it does not take part in the ventilation. So that is dead space. Normally it is constituted by the air present in the conducting zone of respiratory passages, which is called anatomical dead space. So that is measured by using Fowler's method. So this is used to measure anatomical dead space. The patient takes a breath of 100% oxygen to rid the conducting zone gases of nitrogen and then exhales through a mouthpiece capable of analyzing nitrogen concentration at the lips. So initially the exhaled gases contain no nitrogen as this is a dead space gas. The nitrogen concentration will increase as the alveolar gases are exhaled. So nitrogen which is measured following the breath of 100% oxygen must then have come only from the gas exchanging areas of the lung and not dead space. So this is how we'll be calculating the anatomical dead space using Fowler's method. So now we'll see the Bohr equation, which is used to measure the physiological dead space by determining CO2 tensions in the expired and alveolar gas. It is based on the fact that inspired air contains negligible quantity of CO2, almost zero. So all the CO2 in the expired air is derived from the functional alveoli. So in order to derive the equation, FaCO2 is alveolar CO2 and FeCO2 is CO2 from the mixed expired gases, and Vt is tidal volume, Vd is dead space physiological volume. So in an adult with normal lungs, the value for Vd by Vt is between 0.2 and 0.35. So as we said above, though with each breath there will be a component of dead space, so therefore Va is equal to tidal volume minus dead space volume. So therefore Vt minus Vb into FaCO2 is equal to Vt multiplied by FeCO2. So this can be expressed as Vd by Vt is equal to FaCO2 minus FeCO2 divided by FaCO2. So there is not really a truly ideal value for FaCO2, so that can be used in the equation. Therefore, arterial PCO2 is used. So this is substituted into the equation, giving Vd by Vt is equal to PaCO2 minus PeCO2. So F is replaced with P divided by PaCO2. So because there is not really a truly ideal value for FaCO2, we are using arterial PCO2. So that's why we are substituted F with P. So this is all little bit mathematics. So just write these equations on your own. So read the Bohr equation very carefully and then easily you will be understanding this equation. So for measuring the compliance, we have already know the formula, that is C is equal to delta V by delta P, and the normal compliance value is 0.13 liter per centimeter of H2O, and for the lung alone it is 0.22 liter per centimeter of H2O. So specific compliance with both intact lungs will be 0.1 liter per centimeter of H2O. So the compliance, reduced compliance produces a condition that is restrictive lung diseases. So the direct measurement of compliance in the respiratory system is rarely done, and it is only used for research purposes. And likewise, airway resistance measurement, direct measurement is also rarely done. So now we'll see the tests of diffusion. So the diffusion refers to transfer of gases from alveoli to capillary blood across the respiratory membrane. The exchange of gases in the lungs was earlier believed to be dependent merely on the ability of gases to diffuse across the respiratory membrane. Therefore, the term is diffusion capacity. So, the diffusion tests are done by measuring the diffusion capacity of oxygen and CO2. So, this diffusion capacity we will be discussing in the next coming classes when we see the diffusion of gases and exchange of gases across the respiratory membrane. And the next is tests of ultimate purpose of respiration. What is the ultimate purpose? It is nothing but supply oxygen from atmosphere to tissues and removal of carbon dioxide from tissues into the atmosphere. So it is the estimation of arterial blood gases, which is the fundamental test of all the pulmonary function tests. So these arterial blood gases are nothing but oxygen, PO2, PCO2 and pH. So measurement or estimation of these arterial blood gases or ABG is the fundamental test. And next, test during exercise. So because of various physiological reserves, the cardiac and pulmonary functions may be normal at rest in early stages of the disease. But the exercise testing will provide information about the total cardiopulmonary performance of the individual and unmask the abnormality not detected by the function tests performed at rest. So the exercise can be performed on treadmill or cycle ergometer, etc. So the measurement of pulse rate, minute ventilation, oxygen uptake and ABG tension during the graded exercise are very useful, especially when the cause of dyspnea is obscure or unknown. So now we'll summarize the topic. So the pulmonary function tests are performed to diagnose various pulmonary diseases and follow the progress of disease and assess the severity of disease, etc. And they are classified into 4 groups: ventilatory function tests, diffusion tests, ultimate purpose of respiration and tests during exercise. So in the ventilatory function test, again we have seen various 4 groups, that is lung volumes and capacities, dead space, compliance and airway resistance measurement. So in the lung volumes and capacities, we have seen particularly the procedure of spirometry, and the videos we have seen how to perform the spirometry to know the different volumes and capacities. So by using spirometry, we cannot estimate the FRC, RV and TLC. So this is the most important point which is most commonly asked in MCQs. So spirometry cannot estimate FRC, residual volume and total lung capacity. So FRC is calculated using nitrogen washout and helium dilution methods. So we have seen the components of FEC, that is FEV1, V2, FEV2 and FEV3 and their variations in obstructive and restrictive type of disorders. We have seen the flow volume curves of both the disorders, obstructive and restrictive. And then what is a flow volume curve? It is the rate of airflow noted during maximum expiration, which is plotted against the volume change to give the curve. So this flow volume curve is assessed, it can be used to assess the various obstructive and restrictive type of disorders. And then we have seen the PEFR and the video showing the peak expiratory flow meter. So we can do that procedure, simple procedure even at home. So that will give a measure of degree of airflow obstruction. And then FRC, the methods, nitrogen washout, and then we have seen the helium dilution technique. And then in dead space, we have seen anatomical dead space measurement by Fowler's method and also physiological dead space by Bohr's equation. And then diffusion test, that is diffusion capacity of oxygen and carbon dioxide, and then ABG estimation, and then exercise performance, the test during exercise. So that's all the pulmonary function tests we have seen. So hope you have understood. So if you have any doubts, you can message me or text me. So the assignment for today's topic is, I'll give a clinical case study. So no MCQs are given in this class. So you read carefully this case, and then you answer the questions given in the next slide. So that you have to do today. So the question I'll read out. A 55-year-old man comes to OPD complaining of fatigue and persistent shortness of breath, which becomes worse during exercise. The patient has a history of respiratory infection and has chronic cough that is worse in the morning. The patient has smoked cigarettes since he was a teenager. Currently, he estimates smoking 1 pack of cigarettes per day. On examination, patient is in mild respiratory distress with elevated respiratory rate and shallow breaths. An end expiratory wheeze is heard on auscultation. The lab studies revealed FEV1, which is 70% of expected, and PFR is 60% of predicted, and FVC is 90% of predicted. So this is the case study. So now the questions are: diagnose the condition of the patient, list out the various pulmonary function tests, draw the flow volume curve of this patient, and what are the suggestions you want to give to patient in order to stop the progression of disease. So you have to answer all these questions, write in a book, and then submit in the group. So that's all. Thank you. Hope you all are doing good. Read well, stay safe, and stay home.